Good day, I am Ina Marisarita from BSN 32. So for today, I'll be discussing airway suctioning. So airway suctioning maintains a patent airway and promote gas exchange by removing secretion when the patient cannot cough adequately. So we have here blind suctioning and artificial airway suctioning. In blind suctioning, suctioning without a tracheal tube in place, it is done if the patient is unable to expectorate secretions. We have here the oropharyngeal and nasopharyngeal suction. So, oropharyngeal suction requires the use of an airway adjunct. Yung nakikita nyo dyan na kulay green, ang tawag dyan ay Gedel airway. Airway adjunct is used in airway management to maintain or open a patient's airway. It does this by preventing the tongue from covering the epiglottis during vagal stimulation, which could prevent the patient from breathing. The nasopharyngeal suction may be undertaken directly via the nostril without an airway adjunct. If repeated suction is anticipated, a nasopharyngeal airway should be utilized. This is inserted only by those who are trained to do so. So let's move with the suctioning of artificial airway. So, suctioning is often performed through an artificial airway, but the nose or mouth also can be used. Suctioning of both routes is routine for the patient with retained secretions. So, example of artificial airways is patient with endotracheal tube or tracheostomy tube. So, first, assess the need for suctioning. So, assess for audible or noisy secretions, crackle or wheezes heard on auscultation, patient restlessness, increased pulse or respiratory rates, or mucus present in the artificial airway. Because routine unnecessary suctioning causes mucosal damage, bleeding, and bronchospasm. So next, wash hands, don protective eyewear, maintain standard precaution. Explain to the patient that sensations such as shortness of breath and coughing are to be expected, but that any discomfort will be very brief. Check the suction source, occlude the suction source, and adjust the pressure dial to between 80 and 120 mmHg to prevent hypoxemia and trauma to the mucosa. Set up sterile field. Infection is possible because each catheter pass introduces bacteria into the trachea. In the hospital, use sterile technique for suctioning and for all suctioning equipment like suction catheters, glove, saline, or water. Suction the mouth or nose after suctioning the artificial airway. Clean techniques is used at home because the number of virulent organisms in the home environment is lower than in the hospital. Pre-oxygenate the patient with 100% oxygen for 30 seconds to 3 minutes, at least 3 hyperinflation to prevent hypoxemia. Keep hyperinflation synchronized with inhalation. Prevent hypoxia by hyperoxygenating the patient with 100% oxygen using a manual resuscitation bag attached to an oxygen source. Instruct the patient to take deep breaths 3 or 4 times with the existing oxygen delivery system before suctioning. Monitor the heart rate or use a pulse oximeter while suctioning to assess tolerance of the patient with the procedure. Assess for hypoxia. Assess the patient for increased heart rate and blood pressure, oxygen desaturation, cyanosis, restlessness, anxiety, dysrhythmias. Oxygen saturation below 90% by pulse oximeter indicates hypoxemia. If hypoxia occurs, stop the suctioning procedure. Using the 100% oxygen delivery system, reoxygenate the patient until baseline parameters return. Quickly insert the suction catheter until resistance is met. Do not apply suction during insertion. Use a correct size catheter to reduce the risk for hypoxia. and still remove secretions effectively. So, the standard catheter used for an adult is 12 French catheter or 14 French catheter. Withdraw the catheter 1 to 2 cm and begin to apply suction. Apply continuous suction and use a twirling motion of the catheter during withdrawal to avoid injury to tissue integrity. Never suction longer than 10 to 15 seconds. Loss of tissue integrity by trauma results from frequent suctioning, prolonged suctioning, excessive suctioning pressure, and non-rotation of the catheter. Prevent trauma to the mucosa by suctioning only when needed and lubricating the catheter with sterile water or saline before insertion. Apply continuous suction only during catheter withdrawal because intermittent suction does not protect the mucosa and can lead to dropping of secretions in the airway. Use a twirling motion during withdrawal to prevent grabbing of the mucosa. Hyperoxygenate for 1 to 5 minutes or until the patient baseline heart rate and oxygen saturation are within normal limits. Repeat as needed for up to 3 total suction passes. Suction mouth as needed and provide mouth care. Remove gloves and wash hands. Describe secretions and document patient's responses. So that's all. Thank you.